I was thinking of a few things while I was sitting out there. So we're talking about good enough practice or doing good practice. And I think I agree with all the things that have been said. And I think it's that ability to be reflective and to admit when you've got it wrong is really, really important. And I think the other thing is that when I look at evidence, sometimes I'm a bit of a skeptic because it is that issue around, well, it's done in this research with this group of people and how applicable is it to me? So there's the generalisability, but there's also the art of what we do, which is really hard to quantify and to study. You know, the randomised controlled drug trial, easy to put together. But a study that actually looks at that human-to-human interaction and what it actually is and how we quantify that is extremely difficult. And I think the other thing that's interesting is that we like to think that we're rational in the decisions that we make and how we do our work. But I think it's really important to recognise that we're fully emotional. That's how we live our lives, and it's part of what makes us uniquely and wonderfully and awfully human. And I think that that's really important to always acknowledge that in terms of yourself and in terms of the clients that you see.
Yeah, thank you. I wanted to make a more specific comment, and it's partly about the bridge breaking, and it relates to the discussion on outcomes. And this is with my clinician hat on, because I'm also a teacher and I've done research. Actually, what I wanted to throw out there is a question with two possible answers and get you to stick your hands up. Because I've got a hunch what you're going to say. It might be quite wrong because I'm in a different country from usual. But you know, the question is, when you're working with people with alcohol and drug problems, what is your job? Is it 1, to treat alcohol and drug problems? Or 2, to treat people with alcohol and drug problems? Or 3, to improve the quality of life of people with alcohol and drug problems? So have a think and stick your hand up if it's the first one, to treat alcohol and drug problems. Right. The second one, to treat people with alcohol and drug problems. The third one, to improve the quality of life of people with alcohol and drug problems. Yeah, good. So no one for those first 2. And that's kind of how I see my job as well. And when I look at the research coming out, I think it's really useful, and I think that the being guided by the evidence-based practice is absolutely crucial. You don't have the right to use practices that don't have an evidence base if there are alternatives that have better evidence base. But the research, first of all, as has been mentioned, and as Igor sort of talked about, is short-term research generally. When we look at the long-term studies on addiction outcomes, the 20 to 30-year studies, which have got sort of vague outcomes, but they really suggest that those people in treatment actually don't do very much better than the people who have never had treatment with addiction. But what I'm really mindful of as well is that first of all, most research is presented in terms of p-values, and that's great. If you've got a p-value difference under 0.05 for this versus that, then this works, that's great. But my question is, how significant is that? What's its size effect? Is that enough difference to make a clinical difference for me to put effort into using it? The second is that I work with teenagers, and I'm aware that a big part of my role is to sort of help them avoid the negative trajectories that their life might follow over the next 20, 30, 40 years, and try and help push them onto the more positive trajectories by and sort of working with the alcohol and drug and mental health problems. But also my job is to improve quality of life, and a lot of the research that I see doesn't tell me anything about that. It doesn't present quality of life measures. It presents substance use change measures. And so I think the MATE study, which I wasn't aware of, but 3 years, that finding, in treatment, not in treatment, well, there wouldn't be a difference compared to what you'd expect. It raises questions. Does it mean treatment wasn't effective? We don't, or it may have been reported, but I don't know from what was said whether there was any change in quality of life. And there may be. And so as a clinician, I have all those questions about the research, and I don't get enough information to know whether it's worth the effort often given how I think clinically, to make a commitment to that practice. And so that's where I see the bridge falling down. And in fact, part of my role over the past few years, it's what I really, really like, is to actually try and fix that bridge, to try and look at research and translate it into what works in clinical practice and what doesn't, and try and... But I think that's a big part of the gap, and that researchers will assume clinicians will understand the importance of what they say, and clinicians will assume that researchers know what they're doing. Often they do, but that's the translation gap that I often see. So I think it's around what outcomes we use, it's around what our goals are, it's around the fact that as you said when you stuck your hands up, most of us are trying to improve people's quality of life. That's the big picture stuff. That's really crucial. And we can do that through alcohol and drug stuff. Right, but there's also a gap in our thinking, because we all get a bit siloed in our thinking because we get really busy, between quality of life and the things that we can improve to enhance that. So that's the comment I wanted to make at this point.
Now I am going to say something controversial and argumentative. I agree with that we are trying to improve people's quality of life, but we're alcohol and drug workers, and we work in drug and alcohol services, and we also, if people come with drug problems that they want to change, our job is to treat whatever they come with that they're wanting to change in their life, and it might not be their quality of life, it might be their drug problem, and we do need to measure drug outcomes, I believe. Otherwise, we will never be a specialist field. We will always be generalists and not be taken seriously in the health sector. We absolutely need to understand, that that drug use is multifaceted, and there's a whole range of things that might need to change or people might want to change. But we do need to remember that our job is also to change or to respond to drug and alcohol problems specifically.
I agree in terms of outcomes are very important and what have you. And as a director of a service, it's one of the things that we're often challenged with, trying to find what is an adequate outcome in the drug and alcohol field. And I think the reason why a client is presenting and coming back to why the clients and what is the client's goals is sometimes really important in that, whether it is reducing their use, whether it is minimising harm or what have you, that needs to be important. But it's often not what we're reporting on. We're often asked to report upon how many people have completed treatment, how many people have reduced their substance use, those types of things from our funders. And that becomes quite challenging at times when we as a service are trying to be more holistic.
Well, there are a couple of questions here. I want to briefly take on all of them. Research to practice, let's be honest, in most cases researchers talk down to practitioners, telling them, here's what I found, and because of that, this is what you need to do. And researchers rarely ask practitioners, tell me, what do you want to know? And this is something that I guess is missing. The truth is, most practitioners don't give a dime about research. And a part of the reason why is because research currently is written in a language ununderstandable to anybody. It's really hard to understand what these people want to say. So one of the things that researchers probably need to do is translate even the language, translate it into some practically understandable form, so the practitioners can actually, before implementing anything, at least they can understand. So this is one thing. And the question was about good practices, good treatments, or not that good treatments. And there are different levels. And the answer to this question will depend largely on who is the person you're asking. On the micro level, on the clinical level, the interaction level, the interaction between the caregiver and the client. You know what, again, let's be honest, in the last 50 years, with very few exceptions, there is absolutely nothing breakthrough new inventions that we came up with in addiction medicine at all. And like it was 50 years ago, 60 years ago, until today, the most powerful healing helping factor is building a meaningful and functional relationship. And it was 60 years ago, and it's still the case. This is what works. All other things, and I appreciate the medications, CBTs, MI, all of these things are very important, but they all function only if we have an established engagement and established relationship with the client. And it all can be measured. The relationship in the scientific world, the effectiveness and the functionality of the relationship actually can be measured statistically and scientifically as well. So this is something I think we all need to pay attention when we talk about the good practices at the level of real clinical practice. Are we capable in establishing a meaningful and functional and long-lasting relationship with this person? If you ask the same question about good practices to somebody who is at more supervisory position or a policy maker or a decision maker, the answer will be probably different. Frankly, I'm quite tired of the conversations I keep hearing for years. This treatment is better than that treatment. Is treatment X more effective than treatment Y? You know what? I don't care. I really don't care, and I think we are not asking the right question. The question that we all, talking about, and even now, at this second, is what is a good practice, what is a good treatment, and if we ask all of you individually, we'll probably get 100 different answers. But I think the right question here is, regardless what it is, if we ask a question, what a good treatment should do, what type of activity, what you really want to accomplish with any activity in order to consider this activity a treatment. And I think if we ask this question, that will be much easier to come up with the answer. It should be 4 things. Any activity, in order to be considered treatment, should do 4 things, all 4 of them, not just 3, not 2, all 4 of them. Reduce the symptom, improve the functioning, prevent complications, and respect human rights. If any activity, if there is any indication that any activity is capable to do these 4 things, I will be happy and I will think that this is a treatment. Reduce symptoms, prevent complications, improve functioning, and respect human rights. If we can do that, we are all good.
Back to you, Nicole.
Should never leave me with access to a microphone. I actually have a question for Igor and probably Joel as well, in terms of this idea of therapeutic alliance fascinates me. I think most of the studies show that we talk about needing therapeutic alliance and engagement and all of that, but most of the studies show that it's probably about 20 to 30% of the outcomes from treatment. And although I do personally believe that it's absolutely fundamental, but my question is, how then do we account for all these new online studies that show that if you self-pace intervention via a computer, the outcomes are nearly the same as if you're sitting in front of a psychologist or a counsellor? So how do you reconcile those 2 things around engagement and therapeutic alliance and the spirit of MI and all of those kinds of things?
Okay. I was hoping Fraser was going to grab the microphone. No, I don't know. I'm fascinated by that too, and I kind of live on the little MI planet out there somewhere in the universe that a bunch of geeks hang out on. And that's one of the areas that people are developing around motivational interviewing. What they're doing is they're creating abattoir. I want to say abattoir, but that's not what they're creating. What is it? The avatars. Avatars. No, abattoir. No, not that. That would not be. But they're creating avatars, and they're wondering, can you do motivational interviewing if somebody creates their own person and they work with that, and from what I gather, it's getting pretty sophisticated in regards to the interaction that they can simulate or I don't even think simulate, the interaction they can facilitate with the computer. Now, I guess the short action would be is maybe it has to do with the person's original motivation to change when they engage with the computer, and if their motivation to change is more towards one of taking action or just tell me what to do and I'll do it, and I'm really, and they're past the ambivalence, and they could interact with, as Fraser would say, the barman, the postie, the computer. Anybody could give them the right nudge at the right time. That'd be my first guess at it.
And my response would be, because I thought when you said that, that's such a good question. And I thought, what would my 20-year-old son say? And he'd say, well, I actually can interact and I have a relationship with my computer that's stronger and better than it is with half the people I went to school with and I still see. So I think you can form relationships of some kind. I think, the therapeutic relationship we assume is between people. And then I thought, what would my wife say next time I make snide comments about her loving watching Coronation Street? And I think that people have a relationship. It's a social relationship with characters on TV, and I think increasingly it's a sad thing, but people have sort of often stronger social relationships with the characters that they watch regularly on television than they do with people in real life. And so thinking about that, it doesn't surprise me that people can actually engage and have some kind of relationship with online things, especially younger people who have grown up doing a lot of social interaction, playing lots of video games or whatever, and having some kind of relationship with a computer screen. To me, it doesn't seem like it's a relationship at all, but I think to my son it probably does, and I think to my wife watching Coronation Street, she probably has a better relationship with half the characters on that than she does with me sometimes, especially when I'm making snide comments about it. So it just goes to, what is a therapeutic relationship? And I think we're seeing changes in it, and changes of how we need to understand it with the whole new technological world. It's not new, it is. I mean, I'm old, it all seems a bit foreign to me, but you youngsters, it won't be new. But this change that we've had over the past few decades.
I want to make two comments. First of all, therapeutic relationship. I think everybody's right. It's a lovely thing, but I think we need to be careful. There's a lot of very poor practice that happens out there in the context of a therapeutic relationship. And I'm thinking from my point of view as a GP that I'm working with GPs who are not doing this work well. They're continuing to prescribe very inappropriately large numbers of medications. They have a lovely therapeutic relationship with their patient. They've seen them over years. They continue to prescribe really poorly and the person overdoses and dies. So that's an extreme example, but I think we do need to once again be reflective around the therapeutic relationship. The other thing I wanted to pick up on was this idea that we need to be a specialist drug and alcohol group to be taken seriously. I have real concerns about that, and I'm a generalist. I will say that very clearly. But it's a beguiling idea that makes us feel special, and I'm concerned about that because drug and alcohol issues don't exist in a vacuum. They exist in human beings who have other health, well-being, important things in their lives, and I think it's really important that whenever we can, we think about how can this be mainstreamed? How can we play with the big boys in chronic disease, internal medicine? How can we actually engage rather than seeing ourselves as separate? So I have a concern about that. If we silo ourselves out and make ourselves different, we're a small group. We don't have a lot of political capital. We really need to be thinking about how we can actually become part of a more general, a bigger group to actually assist the people that we see.
I respectfully disagree. In terms of the huge stigma that our client group is experiencing on a daily basis within the generalist system. Stigma. It's massively stigma.
But by keeping it separate, you engage in that. I'm sorry, we can't let you go out there because they'll be mean to you. We're playing with that as well by saying that absolutely stigma is an issue.
But the reality is that the other generalists are not dealing with these issues. They're sending people away. They're saying it's too hard, too messy, don't like these clients.
I think also that it's not about making our clients different or having them separate. It's about professionalising the sector and having, the most. If we think about the hierarchy of health and medicine and health, heart surgeons, brain surgeons, alcohol and drugs, kind of down here with child protection and prison treatment and stuff like that. And I've never done this, and I'm just guessing, not being a researcher now, but I think if you were to put the level of stigma against that, people with brain cancer and heart disease are, least stigmatised, and the people down the bottom here that we are, in our sectors are the most stigmatised. And I think the way to reduce that stigma, as Linda said, is to professionalise the field and make us a specialist sector to be respected, and then our clients will also be more respected, I believe.
Okay, can I say something? That this. I'm very pragmatic in my approach, although I work for the large and not very pragmatic organization. But in my professional approach, I'm pragmatic. And speaking about the computers and all this new technology, certainly I appreciated their value, and certainly there are many things we still don't know how important they could be, and probably they could be. This is my assumption. But yet I still haven't seen anybody who is in recovery because of the interaction with computer. I've seen people getting sick from it, but not in recovery. At the same time, I do not, undermine the value of potential high-tech type of things. But being pragmatic, I think in terms of building relationship, establishing relationships, or forming kind of partnership with the clients, which still, in my mind, is the most powerful healing factor. I think we need to think about ourselves and our own behavior, including our own language. For instance, I think it's time to stop using terminology like clean or dirty. Just an example. Because the language is an expression of our thinking. So nobody calls dirty somebody with diabetes with high blood glucose level. Right? Nobody, we test people, we found that the blood sugar is very high, but we don't consider them dirty. So this is something that I think we need to start thinking about our own terminology, the language that we use, because this is a reflection of our relationship with ourselves and with our clients. Also things like relapse prevention. Why do we call it relapse prevention instead of recovery management or recovery support, something that has more positive connotation? These are the kind of very practical, simple things that I would consider positive and potentially promising in a way of being more effective with our clients. Science is without questions. I respect science. I love science. And implementation of evidence-based practices is absolutely important, and we talked about it yesterday. At the same time, let's remember there is another way. There is another dimension of so-called practice-based evidence. Let's be humble. We know quite a lot of things, but we don't know everything. But practitioners like you meet clients every day, you see something is working. Well, that's exactly what probably you need to let the scientists know. I just tried something and it seems like working. Let's try it again. Let's use some methodology. Maybe it will be helpful for other clients as well. The value of practice-based evidence, not just evidence-based practices, unfortunately, in my mind, is undermined by the world community practitioners. And the last thing I want to say, again, relevant to computers and all kind of technologies, which are, without questions, could be very valuable and important adjuncts to treatment. Let's remember, we are lucky, you are lucky living in this beautiful country. I'm lucky living in Vienna, lucky living in California. But there is a huge world around us with millions of people living in the environment of constant war, hunger, with no running water, with no food, with no roof above the kids' heads. What computers are we talking about? Let's take a picture of a larger addiction medicine and medicine in general world that looks sometimes quite different from what we and you probably see in your daily practices and what I see in my nice office in Vienna. But these are still our clients.
All right, it's your turn. Questions, comments, thoughts, ideas? Interpretive dance. Yes.
Igor, yesterday when you talked about the way we consider, like, outcomes is something that's obviously really important. It's something that's really topical. Everyone's talking about it. CUNATA's currently involved in a project to look at it. And the thing that always gets me is the what is the outcome we're looking for thing. And I just wrote down those 4 things you said, Igor. But the thing that really triggered me while you were all talking was the MATES study thing. So if you think about this chronic disease moving in, moving out, then the MATES study turns around and seems to suggest that there was no point doing the treatment because 3 years later they're not still, I don't know, what was the expectation they would be? Like, that they would be abstinent, that they would be at the level of use they were when they exited treatment? Like, like the question that immediately occurred to me was, well, where were they at the day they left treatment? Because I blame my mother for things that I do now, but she hasn't lived in my house for 20 years. So I don't know how fair that is. And that's my problem is that because the client group is so stigmatised, and I mean, I can't tell you the number of times that I've sat in front of policymakers and decision makers and politicians and had them ask me the question of my members, how many people do you cure? I'm like, well, I don't think that's the right question. I think the question is one of quality of life. And I mean, what I would like to know is in that study of the people who were in treatment, how many of them might be dead if they hadn't done treatment? Isn't it enough that they're still alive in a sense? Because and how do you compare that to the people who never had treatment? Like, to me, I don't know.
Well, it's an interesting. Yeah.
That's a really important comment. You've got to be careful what we make of research findings like that. So when I think about those 20-30-year outcomes, which say that there's people who never got treatment with addiction, and the people who did get lots of treatment are not doing any better, but it's quite possible that wasn't a randomised trial. It's quite possible the people who got the treatment were people who needed the treatment more, and without that treatment they would have done a lot worse. So you can't assume that treatment hasn't worked for that group. It just raises questions. And I don't know the nature of the MATES study, but again, you can't make firm conclusions about treatment hasn't worked because you don't know what would happen if those people didn't have that treatment. So you've got to be careful about what you make of the results. You've got to think through. They give you a result and you've got to think and speculate. And that's part of the reason why... Oh, sorry to disagree, you're on a difficult panel, I think, if you're talking about generalists versus specialists, but as an addiction medicine specialist, I think there are questions in there that my psychiatric colleagues don't get. I'm a psychiatrist as well, but people working in other areas of mental health don't get, don't ask. They don't know to ask. And so I firmly defend the idea of specialists as well within addiction medicine, partly for the stigma, but simply because there is a degree of knowledge and skill that you get, and that we all have been working in the addiction field, that our colleagues working in an acute mental health inpatient unit just wouldn't understand about addiction clients that go through there. But that was my comment. Does anyone else want to make?
Other folks?
I can
Nicole.
just respond briefly to the MATES question. The statistic about 96% relapse by 3 years, about 88, I think it's 86% at 1 year. That is based on a measure of abstinence, because those people went into resi rehab and the goal of resi rehab is abstinence. There's no question about that. And I think that we did measure a whole range of other measures. There was quite a substantial assessment. And I completely understand the argument about maybe they would have been worse. There was a control group of people who'd never had treatment, and they looked exactly the same as the people who had had treatment by the end of the study. But I just think that we can do better than do no harm. I think we can actually do better than they didn't get worse. I think we should be aiming for people improving in whatever way that they think is improvement. And that might mean better quality of life. But I think for a lot of our clients, I think for for most of my clients, it's either reducing their drug use or assisting with their mental health or quitting drugs. That's what they come to me to get help with. And if I just said, well, you're lucky you didn't die from my treatment, I just don't think that's enough.
One of the things that... Oh, go ahead. This was the whole. Yeah. No, I don't know. I think one of the things about research and reading lots of different kinds of research is it generates more questions. I don't look at it as an indictment. How do you know you should be doing something different if you don't know what you're doing, right? So I think it creates more questions. Igor said that it's important for people to stay in treatment for 90 days. It's not just residential, it's any kind of treatment, community-based treatment. As long as they're in a facilitated change process that looks after them in the long run, they do better. That's what the research indicates.
At the risk of being controversial, I worked in a couple of other health sectors, and one of the things that Igor said to me really resonates about outcomes. And actually, the overarching statement would be about quality of life in any health sector. But where Igor talked about improving functioning, reducing symptoms, preventing complications, and respecting human rights is implicit in most other health sectors in terms of treatment outcomes. So what I would ask the panel is, what have we learned from other health sectors that we can learn from to say, what do we want to be doing in the drug and alcohol sector about good practice and outcomes?
Can we open that up to the whole audience too? What have we learned from other sectors?
While they're thinking, can I say something? You know, the four criteria for treatment that I mentioned: symptom reduction, improvement in functioning, prevention of complications, and human rights. Actually, these are not unique for addiction treatment at all. You can apply the same criteria for any kind of treatment of any chronic and relapsing condition: diabetes, cancer, hypertension, asthma, all of them, and you will get the same thing. And actually, it's somewhat related to your question about full abstinence or not full abstinence. You see that one of the criteria is not symptom elimination, it's a symptom reduction. And now, considering the fact that we are working with clients typically who are dependent, meaning their brain pathophysiology has changed significantly. They're not capable to stop, just say no, like Nancy Reagan wanted, and we spent billions of dollars on this nonsense. And these are people who are not capable of doing that. This is why they need treatment. In this case, the symptom reduction means, and by symptom in these patients, I consider the most important symptom is the compulsive drug use. This is what I'm trying to reduce as one of these four steps. In this case, the full abstinence would be wonderful, but in some patients, as you know, it's not achievable. If we can do something and we can reduce the intensity, the frequency, or the danger of the drug use, so the symptom reduction will happen, I will be happy. Who knows what will happen next? So it will be fine with me, at least as an initial step. So when I work with clients, I never consider the full abstinence as the ultimate and the only outcome. No, there is a continuum of different possible outcomes. And I don't know if I gave you any answer to your question.
Yes, Cameron.
Social worker. So let me be the first to say society is to blame. My point, though, is that in a study such as MATES, I was working in Logan at the time, and MATES was recruiting people from that community, and that's really a community saturated in problems and poverty and unemployment. And I wonder, how much do we expect of individualised treatment for people who often don't have control over some of the circumstances that are putting them at risk of these problems? And if people live in a drug-saturated community full of poverty and unemployment, does them coming into contact with our special magic AOD voodoo, is that really, are we overestimating what we can achieve and what our clients are able to achieve sometimes in those environments that they might be living in or coming from?
I think it's really important that we get down to why is the client coming into treatment, and even within those environments, like part of my service is Logan, so I know of the low socioeconomic status of down there, but it's clearly identifying what is the reason that they're coming in. Often they're coerced by whoever and what have you. And they're going back to other things, but it's looking at the holistic as well. And I think that's one of the excellent things that we can do in drug and alcohol, and it's why we need to keep our clinicians competent in terms of what they're doing, how they're doing, in terms of, as Nicole was saying earlier, that ongoing supervision, making sure that everyone in the sector as well is making sure that they keep up to date and do that professional development. They don't do a course 20 years ago and expect that they're still on the ball about everything. So, yeah.
Yep.
Let me say something again. Let me put it in perspective. What you're talking about is something that I've seen several times in very strange environments, sometimes very dangerous environments. I mean, I've seen children soldiers who are loaded with amphetamines and they're 12 to 14 just to make them fight longer and more effectively. I've seen that, and I've seen these kids, and I communicated with these children. As soon as you take them out of this danger, give them a bowl of hot soup, have a simple conversation, and put them in a shelter, guess what? I did not see any of these kids showing any craving for amphetamines. I mean, just because of the environment has changed. I mean, when I was in a couple of prisons in Africa, this was exactly, that gave me a clear picture of what hell looks like. Okay, when we took some of these people and placed them in residential treatment, and I physically walked these people out of this prison with permission, of course, and took them to a residential treatment. All of these people had very long exposure to drugs, and many of them probably have been dependent. I did not assess them. They saw a white bathtub with hot water, and I didn't see any craving for drugs. This is something that was actually culturally, for them, phenomenally important factor for their recovery, just changing the perception of what's important in life. What I'm talking about is a simple, it's not actually simple, but this is something that we all know. This is the outreach. Instead of waiting for these people to come to us, which in many instances will never happen, it makes sense to think about what is that we can do to go there and offer them something that might be attractive to them, might be of interest to them, and who knows what will happen.
I was thinking about what you were saying, Cameron, and I remember Marie Thiessen's presentation on the 11-year follow-up. I believe it was Marie, wasn't it? Did the 11-year follow-up and then broke it down to all the different issues people had. And it took me back to a couple of studies, one by Professor Gareth Edwards in the UK and then George Valiant in the States, where they did naturalistic studies following 100 heroin-dependent men in the UK and 100 alcohol-dependent men in the US. And they didn't do anything to them, with them, or for them. They just followed them over 10 years. And if they could, what they found is that the group that they could keep up with, if they could survive their substance use, at around 7 years, things started to change for them, and then it just got better when they stopped at 10 years. And I remember looking at that going, well, why don't we just, set the clock? Here's a diagnosis. I'll talk to you in 3 years. We'll see how you're going. And we'll do that. And it was interesting with Marie's research, because there was a group of people who had a similar trajectory in that. So I think time is a big factor. And I don't discount what happens every day. I don't think there's anything magical that psychotherapists, alcohol and drug counselors, psychiatrists, psychologists do. Most of the change that happens out in real life. Right? It's people that they get out, they finish a program, they finish a counseling service, and they go back in their real life where there's poverty and there's strife, and they find a way to make individual, if not systemic change that's meaningful, and then they can move towards something different. So I think I come from a very relational attachment theory sort of place with all this, and I think our relationships that we have with people are the strongest things that we have. And what we do with the time and we have with them is really important, as people are saying. And we don't know everything, but we're trying to figure some things out. So I don't know. I mean, it's easy to look at data like the MATE study and the outcome studies and go, God, gee, we're just rolling this ball up the hill, aren't we? And the reality of it is we are looking at quality of life improving over time. And we need more research that asks people, so are you happier now than you were 3 years ago? Yeah. Are you still using? Yeah. Okay. That's good. You know, are you happier now than you were 3 years ago? No. Are you still using? No. Well, don't start using, but maybe you ought to do something different. You know? So I think we need to be more attuned to what Hester was saying, to the emotional relatedness aspect of it as well too, and then what we do in that space and the time that we have with people, we do what we can. You know, so I don't think we have all the answers. My question is, what can we do differently that might work a little better? And I don't know what that is. That's my sort of quest to figure out, as opposed to put down the flag and say this is how we do it and we're never going to change. And we're at time. Final question. Who has the final question for us? Or a comment? Anyone have a... Yeah, Lee.
I'm kind of left feeling a little bit confused here, and I'm wondering whether I'm hearing from some of you, and particularly you, Igor and Joel, a message of we really need to have the relationship, and the relationship itself is sufficient. And I'm listening to you on Wednesday at the Motivational Interviewing Workshop. My impression was you were saying we must have a relationship. Now, whether we get that through face-to-face or whether we get that through computers or whatever, you have to have the relationship in some way. But then there are things that we can do as clinicians that will influence people so that they are more likely to be able to change, or things that we can do that make them less likely to change. So I wouldn't like to go away thinking all I've got to do is have a lovely relationship, because I don't think that's what you were saying. Yeah. Is that right?
Let me, Joe, let me respond to that. You know, I didn't say that relationship is sufficient. It's not sufficient. The practical and good quality and pragmatic treatment with good quality is absolutely needed. I mean, there is no any evidence that one treatment is better than another treatment. Our clients are different, they respond differently. But treatment is extremely important. A relationship by itself, just alone, is not sufficient. Think about it. A relationship is like petrol in your car. The petrol in your car does not define where are you going, whom are you going with, when are you going to will stop for lunch. It doesn't define any of this, but you are not going anywhere without it either. This is what I'm talking about. Relationship, building a meaningful, therapeutic, active, and functional relationship is the prerequisite. And from this point further, you can build, you can apply, you can implement any kind of treatment that you feel comfortable and you believe is needed for this patient. But you cannot do anything if you don't have the foundation. And the foundation is the relationship.
I heard you right in that case.
Any final comments from anyone on the panel? No. Look, join me in thanking Joel for chairing, Hester, Igor, Todd, Nicole and Linda. What a fantastic session. That was a really rich discussion. Thank you very much.